that. So welcome everyone to today's IQ Forum. My name is Stacy Farr. I'm the co-director of the Healthcare Institute for Innovations and Quality at UMKC. And today we're here for one of our IQ Forums. We really love these sessions, these forums, because we bring together different stakeholders to talk about their perspectives on, the same healthcare topic, but you're hearing from a number of different perspectives, whether it be a payer, a provider, a community-based organization, a patient, et cetera. And so today we're really excited to talk about new directions in senior care, and we have a really great lineup of speakers as well. So just kick off a few slides here. So this is the list of our IQ forums for 2026. And so obviously we are here in the middle at May 21st on new directions in senior care. So we look forward to having you at future ones as well. And so today's session is really looking at the landscape of senior care, and it's shifting toward models, as we know, that might prioritize autonomy, technological integration, and person-centered health strategies to meet the needs of growing and more discerning aging population. And a major trend is really moving away from maybe traditional models of care and more aging in place models, supported by expanding home care medicine and resources like the National Institutes of Aging that help seniors remain in their homes safely for as long as possible. We also know there's a lot of technological advancements that are playing a critical role in this shift, and a lot of the changes as well as policies to help engage and advance and expedite these important shifts as in America's aging culture. And so today we're going to really explore and talk about different policies and efforts around expanding the regional activity here in Kansas City around senior care. And I'm sure there will be some kind of national influences as well. So here is a high level of who's all speaking today. We have, we're going to be kicking it off with Kim Stupika Dobbs, who is with the Centers for Medicare and Medicaid Services, giving us a kind of a CMS and a public payer perspective as the regional administrator. And then we'll hear from Laura Loiacono, accented the wrong way, who's a principal at L3 Policy Solutions, an advisor for Missouri Council on Aging, and contract administrator for Jackson County Senior Services Fund, giving us a public resources perspective on advocacy and action. We'll then hear from Heath Rath, who is the VP and Executive Director of PACE for Midland Care Connection. And then we'll have a policy perspective from Hector Rodriguez with the Kansas Long-Term Care, who's the Kansas Long-Term Care Ombudsman. Another word, man, I just can't pronounce anything today. But that'll be a great policy perspective as well. And then we'll have a little time at the end. So if anyone has, questions now, feel free to drop them in the chat, or as you hear from a speaker, drop a question in the chat. Otherwise, we'll have kind of a panel and a little bit of Q&A discussion at the end. So you can jot down your questions if you're in the room or online and ask those as well, so we can have a little bit of discussion. And then we do hope many of you can join us in the summer on July 16th, which will be our next IQ Forum on Rural Health Reimagined. So with that, we do also want to thank a number of our sponsors, the Frontiers Clinical and Translational Science Institute, BioNexus UMKC, are good supporters of the IQ Forum. So we thank them for their contributions for sponsoring us. And with that, I am going to stop sharing my screen, and I will hand the floor over to Kim Stupika Dobbs, who is with CMS, and will chat with us about CMS's perspective.
Awesome. Thank you, Stacy. I appreciate it. Yes, hi, I'm Kim Stupika Dobbs. I am the regional administrator for CMS here in Kansas City. So we're located at what is, for our region, we serve the states of Iowa, Missouri, Kansas, and Nebraska. So I think I've had the pleasure of meeting some of you before in different conversations, and I believe a number of you also have met my colleagues along the way in different interactions as well. So it's good to see many of you again today and meet those who I haven't had a chance to meet. So today I'll be discussing CMS and its critical role in senior care in the United States. So as probably many of you know, CMS serves more than 65 million Medicare beneficiaries, the majority of whom are older adults. But CMS is more than just the payer of the healthcare claims. CMS helps shape the healthcare system itself by influencing how care is delivered, how quality is measured, how technology is used, and how the healthcare dollars are protected. As America's population ages, CMS's responsibilities are becoming even more important. Seniors today are living longer, often with multiple chronic conditions, behavioral health needs, and increasing expectations for coordinated technology-enabled care. So today I'll cover a quick touch on Medicare coverage and then quality and innovation. We'll talk a little bit about the CMS health tech ecosystem that you may have heard a little bit about, behavioral health initiatives, and then touch a little bit on the fraud, waste, and abuse work that is happening at CMS right now too. First, just covering bases on Medicare coverage for seniors. So again, and apologies if people obviously are already familiar with this, but I think it's worth stating. Medicare is obviously the foundation of the healthcare coverage for older adults in the United States. And so CMS administers the Medicare program and then establishes the rules that govern how the care is accessed and reimbursed. So Medicare is divided into a few different parts. We have Part A covering hospital care, skilled nursing facilities, and hospice services. Part B covering physicians visits, outpatient care, preventative services, and durable medical equipment, or DME. And then I'm going to skip to Part D, which covers prescription drugs, and then Medicare Advantage, or MA, or Part C allows beneficiaries to receive those benefits through private health plans approved by CMS. So then CMS determines what services are covered, what quality standards provider must meet, and how providers are reimbursed for those services. These policies directly impact affordability and access to care for seniors across the country. CMS has also increasingly focused on preventative and whole person care. So here we're thinking about things like annual wellness visits, screenings, chronic care management, and expanded telehealth services. And these efforts are important because many seniors are managing multiple chronic conditions simultaneously, like diabetes, heart disease, mobility challenges, and cognitive decline. And CMS policies help ensure seniors can access coordinated continuous care rather than fragmented services. Again, one of the major CMS responsibilities is ensuring quality and safety across the healthcare system. CMS establishes national quality standards for nursing homes, hospitals, home health agencies, dialysis facilities, and other provider organizations that serve seniors. These standards are enforced through certification surveys, inspections, reporting requirements, and other oversight activities. CMS also provides public transparency tools that help beneficiaries and families make informed healthcare decisions. One example is the 5-star quality rating system for nursing homes. Another is the Care Compare website, which allows consumers to compare providers on quality measures, staffing, patient outcomes, and patient satisfaction. CMS quality initiatives focus heavily on reducing preventable harm. That includes reducing hospital-acquired infection, reducing avoidable readmissions, improving medication safety, and strengthening care coordination and discharge. This is especially important for seniors who are often more medically vulnerable and may transition frequently between hospitals, rehab facilities, specialists, and home health care settings. In many ways, CMS acts as both a regulator and a public accountability driver for healthcare quality nationwide. As we think about payment and care and innovation, one of the things that CMS kind of acts as acts through innovation in payment and care delivery models. So historically, healthcare operated under a fee-for-service system where providers were paid based on the volume of services delivered. CMS has been leading a shift toward value-based care, which emphasizes quality, outcomes, and efficiency instead of volume alone. So here, think about things like accountable care organizations and ACOs, bundled payment initiatives, value-based purchasing programs, and primary care transformation models. These programs encourage providers to coordinate more effectively, improve communication among care teams, and focus on prevention and chronic disease management. For seniors, this could mean fewer unnecessary hospitalizations, better medication management, and more coordinated transitions between care settings. CMS is also encouraging innovation in home-based care models and programs that support aging in place. This aligns with what many seniors prefer, receiving care safely in their homes and communities whenever possible. Overall, CMS payment policy is one of the most powerful tools in influencing how healthcare evolves in the United States. As we think about kind of new priorities or things that are on the horizon, right now, one of CMS's priorities is building a modern health tech ecosystem. The goal is to create a where data flows, where data follows the patient. Information is securely shared across settings, and technology improves both care delivery and patient experience. A major focus area is interoperability, which means enabling health information systems to communicate with one another securely and efficiently. This helps providers access more complete patient records and reduces duplications of tests and services. CMS has also promoted patient access initiatives through APIs and digital health tools. Programs such as the Blue Button allow Medicare beneficiaries to securely access and share their health information with apps, caregivers, and providers. This creates opportunities for innovation by allowing developers and healthcare organizations to build tools that support medication management, care navigation, chronic disease monitoring, and personalized care planning. CMS is also working to reduce provider burden by modernizing digital quality reporting and streamlining administrative processes. For seniors specifically, digital health tools can improve access to care, especially for individuals in rural areas or those with mobility limitations. Telehealth expansion has also become increasingly important for behavioral health services, chronic care management, and routine follow-up care. Ultimately, we want to be connecting beneficiaries with digital infrastructure designed to improve care coordination, patient empowerment, and healthcare outcomes. One other item that we recently, you may have heard recently announced, is a re-energizing of the CMS behavioral health strategy and how behavioral health integration across the healthcare system would look. So CMS recognizes that behavioral health is essential to overall health, especially for older adults who may experience depression, anxiety, substance use disorders, loneliness, or cognitive decline alongside physical health conditions. So the CMS behavioral health strategy strategic pillars are focused on person-centered health promotion, early prevention and care opportunities, and integrative care across physician and behavioral health. And then even in particular for children and adolescents, right? Because if we think about just CMS wide, yes, we have Medicare, but we also have Marketplace and Medicaid. So it does span that thinking as well. One of the other pillars is driving high value and evidence-based care with a focus on prevention and treatment through value-based payment models and quality measures, as we talked about earlier. Enhancing access to effective technologies such as mobile and digital treatments and tools to enable high quality care and encourage healthy choices that can support wellness. Engage and coordinate with states, people, providers, and communities for effective impact, and coordinate with our federal partners to synergize and align federal programs in evidence-informed and data-driven manners. And then we are also talking a lot and playing a critical role in protecting the integrity of the Medicare program by combating fraud, waste, and abuse. So the fraud, waste, and abuse costs the healthcare system billions of dollars every year and can directly harm beneficiaries through scams, through unnecessary services, or through identity theft. And we have been doing, particularly here in our region and across the regions across the country, a lot of outreach to community organizations, directly to Medicare beneficiaries, across the board, bringing attention to how people can be reviewing their Medicare summary notices, or, what to be looking for, how people would, should be aware, things like making sure they know if they get a new or protecting, obviously, their Medicare cards, but if they get a new Medicare card in the mail, it's going to be a paper Medicare card. There's been scams that send like laminated Medicare cards, and those are not real. So there's lots of different things, but really trying to get the word out about what to look out for and then how to report that. So there's been a lot of work going on to get that information out. But then also looking at the side of prevention, detection, and enforcement. And on the prevention side, looking at using tools like advanced analytics and predictive modeling. On the detection side, we monitor provider behavior, claims activity, and utilization trends. And then on the enforcement side, we collaborate closely with the Department of Justice and the Office of the Inspector General and other law enforcement partners to investigate and prosecute fraudulent activities. And as I mentioned, some of the other on the provider side, or just what we have seen over time, are things like fraudulent billing schemes that involve durable medical equipment, home health services, prescription drugs, and telehealth. CMS also strengthens provider enrollment and screening requirement to prevent bad actors from entering the Medicare system in the first place. Obviously, protecting the Medicare program and protecting the program integrity is essential, not only for the financial stability and sustainability of the Medicare program, but also for maintaining public trust and ensuring resources remain available for legitimate patient care. Lastly, CMS also supports long-term care services for seniors through both Medicare and Medicaid programs. This includes oversight of nursing homes, skilled nursing facilities, home health agencies, and home and community-based services. A growing focus for CMS is supporting aging in place, which we heard a little bit about earlier, which means helping seniors remain safely in their homes and communities for as long as possible rather than moving into institutional settings unnecessarily. Programs that support care coordination, caregiver support, home-based services, and integrated care models all contribute to this goal. And I think we're going to hear a little bit later, but we also support models such as the PACE program of all-inclusive care for the elderly, which integrates medical, behavioral, and social services to help seniors remain in their communities. This shift toward patient-centered and community-based care reflects both patient preferences and broader health transformation goals. In closing, I just wanted to restate that we do understand that we provide and play a central and evolving role in senior care in America. We provide healthcare coverage, establish quality standards, drive innovation, build digital infrastructure, advance behavioral health integration, protect healthcare system from fraud and abuse. As the population continues to grow, CMS's leadership in value-based care, health technology, behavioral health, and program integrity will become even more important. And CMS is endeavoring to continue to lead this work. And thank you, and I will turn it back over to Stacy.
That was great. Thank you very much, Kim. That was a good lay of the land for CMS, and I think taught a lot of us a lot. And I'm sure we'll have more questions about a lot of those in the Q&A. So thank you. So now we'll turn it to our next speaker, who I'm afraid I'm probably going to mispronounce again, but I'm going to give it a shot. So Laura Loiacono. Loiacono. It's such a beautiful name. I just wish I could keep it right every time she says it.
So many vowels. So many vowels.
It's so many vowels, but they're beautiful. I just keep putting the emphasis on the wrong syllable. Anyway, but she's going to give us public resources perspective on advocacy and action, expanding public funding for older adults to improve health and independence through Missouri's senior levies. So really look forward to your perspective, Laura, and the floor is yours. Thank you.
Hi there. Thank you so much for inviting me to participate. And with a little luck, I'll be successfully sharing my screen.
Looks great. Yep.
Awesome. So, yeah, I'm taking a different topic today. I'm going to talk to you about more about public policy and how taxpayers and voters and public officials can respond to the growing aging population. And so I kind of have a bit of a case study for you that we're going to talk about the senior levy initiatives, which is in Missouri. So, looking at Jackson County, because that's where most of us are right now, we know that we reflect what's going on in the broader state of Missouri, where more and more seniors are living in poverty. And by seniors, we mean typically people 60 and older for this purposes. So 21.7, nearly 22% of our seniors are living in poverty in Jackson County, compared to nationally about 11%. We have an older population that's set to double by 2030, so we'll have more older people than children for the first time ever. I'm sure this isn't a surprise to many of you. And then, unfortunately, the unfortunate reality is that fewer than 2% of charitable contributions in Kansas City and nationally go towards senior services. By senior services, we mean things like in-home support, caregiver support, care transport, Meals on Wheels, and all the things that help seniors live longer in community and in place. So as we know, healthcare alone is not enough. To ensure that older adults can get to their appointments, medical appointments, but also to the grocery store and other places, they need to eat nutritious meals, live safely at home, manage their daily activities, stay socially connected. I think we're more and more understanding how important that is the effect of isolation on seniors on loneliness. And then support for caregivers, which is absolutely essential, as many of us have probably been caregivers ourselves. So when I say senior services, what I'm talking about is things that address those issues that I just brought up. They're not just grant-making tools, but they are public funding mechanisms that strengthen the community conditions older adults need to stay healthier and independent longer. And I like to say keeping seniors living in community, not just necessarily in their homes, but staying in the community in the places they call home. So senior services incorporate a broad number of services like transportation, nutrition like Meals on Wheels, home delivered meals, in-home care where you might come in for 4 or 5 hours a week to help people put away groceries or maybe do some minor home repairs. Make sure those social connections and participation at our senior centers is vital. This is particularly crucial in rural areas, and home safety, wellness, and fall prevention programming. So when we were talking with the existing senior services providers in Jackson County, this is a kind of the refrain that we heard from many other providers. Many of our clients need services beyond our scope. Seniors need access to quality and medically tailored meals, sometimes culturally appropriate meals, but also meals that are appropriate for diabetics or other health concerns, pre-existing conditions they may have. Waiting lists are far too long, so even if the services are available, our friends over at the Area Aging Agency will tell us that they have way more demand than they have ability to provide home delivered meals, for example, or rides. It's hard to serve the growing number of seniors in homeless or domestic violence centers. I think it's always important to remember that if you had problems and issues that plagued you when you were a younger person, like you're in a domestic violence situation or substance abuse, that those programs don't go away when you go on Social Security. We have to figure out how to serve the people with those needs. And many of our clients are non-English speakers. As the speaker before was talking about all the things that you need to know, we heard a lot from our partners, especially up at Mattie Rhodes, that their seniors primarily Spanish speaking there, but we have a lot more languages spoken in Kansas City. They have a hard time accessing in their native language. And they need translators, but they also need culturally appropriate explanation of what the benefits are. And then, of course, technology, that more and more things are going online, and there's a digital divide that's particularly steep for non-English speakers and for people living in poverty. So a senior levy is a state statute from about 25 years ago. The Missouri legislature decided to allow counties to ask voters if they would like a levy of up to 5 cents for $100 assessed, which is way more complicated. It's not as complicated as it sounds, but for an average homeowner household, for the average householder of a home that's about $200,000 in value, that's about $19 a year extra tax the levy would assess against homeowners. And so the statute says that all of the services collected through that property tax levy would go towards senior services. And all those funds would benefit seniors ages 60 and older. So Jackson County was the 56th county in the state of Missouri to pass such a fund, and they passed it in November 2024. I'm going to talk to you a little bit more about that. Our friends up in Clay and Platte County have more long-standing senior levy funds, and they are able to provide, $2 million a year in senior services to their providers. And then we had another county just join the list. We're now 57 counties strong, and the city of St. Louis. Madison County down in southeast Missouri just passed a levy in April. So in Jackson County, this just is a kind of an overall what we did to successfully put the question of should we levy ourselves in Jackson County 5 cents on every $100 valued. We had a coalition of senior serving agencies that came together and explored this topic of, why is it taking Jackson County so long to get this on the ballot, but also we could really need this. Our needs are acute in Jackson County. The octogenarians are the fastest growing population, and many of those are living in poverty. So we formed a coalition that had loosely about 40 agencies across Jackson County, but we also had a lot of assistance from our friends in Clay and Platte County that came down and kind of tested the power of passing a senior levy. The coalition did a needs assessment. We surveyed about 100 individuals and agencies to ask what the top needs of seniors are. There was a political poll that polled likely voters to test how likely it would be that they would vote yes, let's say, and the messages that the likely voters that seemed to work the best on the likely voters. For example, people were very concerned about caregiving. People were very concerned about Meals on Wheels. And so that political poll kind of helped shape the messaging for the coalition when they decided to take it to the ballot. First, the coalition had to go to the Jackson County legislature and the county executive and ask the ordinance to be placed on the ballot, which would put the question on the November 24 ballot. So they were able to do that. That was probably the hardest part of the whole story of getting this passed, but the legislature did refer it to the ballot in August. And so the voters had a chance to vote on the ordinance in November 2024. It passed with 54% of the ballot of people voted. It was the very last question. I don't know if you can picture what November 2024's ballot looked like, but it was pages and pages and questions. And the senior levy was the very last question on about a 12 to 13 page ballot. And people, the majority of people voted yes for it. some delays happened, which I don't need to go into, but a board was assembled and appointed by former county executive Frank White. The current county executive reappointed them in 2025, and the board started meeting. Right now, they're setting up the organization, mission, vision, values, needs assessment, that sort of thing, so that they can make sure that the grant making, which lies solely with the board, it does not lie with the county executive or any elected officials. How the funds are distributed is solely the purview of the citizen-run board. And they are hoping that funds will be dispersed in the form of grants no later than sometime this fall. What was created was a 501c3 organization that does use the taxpayer dollars. I mentioned the 7 members. $8.3 million in property taxes is what's being held right now to be distributed. That's a little more than we expected, which is wonderful. And it makes Jackson County senior levy the largest by far in the state. St. Louis City is about 4 million. Springfield is about the same. So this is a wonderful new opportunity of $8 million set aside for seniors. All those funds are used for seniors that live in Jackson County. So revenues collected through a property tax. So when you get if you live in Jackson County or anywhere else, when you get your property tax bill, it will say on there that it's a senior services levy. And so it's very clear of how much you will be paying when you get your property tax assessed. Again, the board sets the priorities and determines the funding. The funds are going to be distributed through nonprofit agencies and other partners, like in some cases, maybe government agencies, health department. But that's the important thing to remember is these funds are not here to supplant or restore lost federal and state funds. They're here to power up what providers and what seniors need. And so that's why the coalition worked so hard for this, because they knew that these are going to be new funds. There'll be an annual audit and oversight that the board itself will undertake and reporting back to community, which is really important to keep that transparency and accountability up. So as I mentioned, what's next is right now the board is going through planning and budgeting. That $8.3 million is now being held in a bank account. The board is going through grant priorities and setting their goals about how they want to make these grant funds most accessible to the agencies. So what it means for the ecosystem is that this is a new funding opportunity, money that did not exist before, that 55 other counties had that Jackson County did not. Supported for aging in place and in communities, these funds must be used for programs that help people stay in their homes longer. We had a lot of support and data and help from even long-term care facilities and other nursing homes or other housing, senior housing, knowing that this would not go to them, to those agencies, but knowing that it is very expensive, as you all know, to pay for long-term care. Most of us, many people will need that, and we want people to save their money and age in their community as long as they desire to, and provide them the supports and help them save money, because they are going to need it when they have to go into assisted living or senior, some sort of care situation. We'll also hope that there'll be opportunities for collaboration between senior serving agencies and to maybe power up some good ideas that we haven't had the funds to support, or increase the capacity of agencies across the county. If you think about Jackson County, there's great swaths of rural areas, and they're going to have maybe different needs than those that live in the urban core, where there might be public transportation in the urban core, but there is not in Eastern Jackson County. So the board will have to take all of those things into consideration. We hope that this will yield better data for the needs of seniors. I keep envisioning a kind of heat map of where the people are that need the services, especially low-income people, isolated people, and matching those with the agencies that can serve them, or if they had greater capacity, that they could provide those services like minor home repair or rides, etc. And then we're hoping to have a stronger bridge between healthcare, social services, and community-based supports. So again, prevention is a lot better in having people age in their homes longer to keep them out of the healthcare system. And I'm just going to end with this. This is how you can get a hold of me. If you want to read more about this, we have a very basic website. You're seeing a screenshot, and that is jacksoncountyseniorsfund.org. We will be announcing grant opportunities there, and you can sign up if you want to get on a newsletter when those start going out for opportunities that are going to come up. We also are a 501c3. However, we operate because we do have public funds. And so on there, you'll find notices of all our meetings. Those are all open to the public. Our paperwork that you might need to see, you can request, as well as minutes from our meetings. Those are all going to be on the website. And with that, I will stop. And I think we're going to take questions later, right?
Yes. Yes. No, thank you very much, Laura. That's fabulous. I did not even know about this at all. And now what a great resource for Jackson County patients or, population seniors. So that's really wonderful. And I'm sure many people in the room are taking notes and are already ready to see what the board priorities are so they could submit opportunities. Thank you. We'll take some questions at the end. Yes. Okay, so now we will turn it to our next speaker, who is Heath Rath, who will be giving us an all-inclusive care perspective and talking about expanding PACE into rural America. So really great topic for today. So Heath, the floor is yours.
Yes, 1 second. Let me share my screen. I can swap.
Yep.
Okay.
Perfect.
If you're able to see it correctly.
Looks good.
Okay, well, thank you so much. I appreciate you inviting me here to speak about this topic. I wasn't aware that your next month's IQ Forum is about rural healthcare. So if you need speakers, this topic could really apply to both, I think. Because today I'm going to be talking about expanding PACE into rural America, how rural health transformation funds are really supercharging the PACE program. So again, I'm excited to share a little bit about PACE with you, as well as some details about the rural health transformation. So if you are not familiar with PACE, then you're certainly not alone. It's a pretty niche model of care. So I'm happy to provide a quick overview of the PACE model first. So PACE stands for Program of All-Inclusive Care for the Elderly, and it's really centered on the belief that it's best for families and older adults with chronic care needs and their families to be served in the homes and communities that they love for as long as possible, whenever possible. And the main goal of the program is to really allow nursing home eligible older adults to age in place rather than being institutionalized prematurely or inappropriately because of a lack of care coordination or a lack of available long-term services and supports. So once you're enrolled in a PACE program, the program is fully responsible for providing all of your health and wellness needs. The PACE organization essentially becomes your one-stop shop for all of your healthcare provision. And PACE programs primarily aim to keep their members at the highest level of function and independence possible to ensure that they are preventing preventable hospitalizations or utilization by really wrapping services around the enrolled participants by the interdisciplinary care team. So in that way, by delivering all needed medical and supportive services, PACE provides that entire continuum of care to older adults while remaining their independence in their homes and in their communities. PACE programs provide all care and services that are covered by Medicare and Medicaid, as well as some services that are not traditionally covered by Medicare and Medicaid. So one example I use often here is Medicare and Medicaid cover a wide variety of things, but there are services that are needed that may not be typically billable services in the fee-for-service world. So, for example, if you have an older adult who has lives at home, they have COPD, but they don't have any working air conditioning in their apartment or in their home. Here in Missouri, it's a hot summer, and you get one of these 105-degree days with high humidity. That can result in a COPD exacerbation that ultimately results in an ER visit and a acute stay that costs tens of thousands of dollars and has pretty negative impacts and outcomes on the individual's well-being. That could have been prevented by a window AC unit. So if the interdisciplinary care team in a PACE program conducts their assessments and determines that, hey, this person would benefit from a window AC unit, and that's going to prevent the COPD exacerbations, and that's going to prevent the hospitalizations and the ER visits, that's spending $150 versus tens of thousands of dollars for those preventable catastrophic events. Same thing with functional capacity. If the OT goes into the home and identifies that a replacement of some shag carpeting from the 70s would be add value in that it reduces the fall hazards or trip hazards for an older adult. Well, you're ripping out some carpet and replacing it with linoleum or LVT for a couple $1,000s versus the potential of having a fall with a hip fracture and a short-term rehab stay and all of the cost and pain and suffering associated with that. So that's why I always like to point out that PACE programs really do become that one-stop shop and are 100% responsible for all Medicare and Medicaid services, as well as other services that aren't typically provided as quote unquote prescribed by the interdisciplinary care team. So, that care team, they're really the bread and butter of the model. They meet daily to discuss the current care needs of all PACE members, and they frequently interact with all the participants so they can really gauge and catch really small issues and begin treatment for them to prevent them becoming much larger issues later on. And all decisions are made by that interdisciplinary care team to determine really what's best for the participant to keep them as medically, physically, socially stable as possible over the long term. And since it is considered long-term care, the IDT doesn't just treat those symptoms. They're really looking at developing plans for preventable interventions to ensure that future health concerns are addressed as the participant ages within the program. So as you can see on the slide here, I've mentioned the IDT or the interdisciplinary care team several times. By regulation, that consists of 11 individuals, anyone from your registered nurse to your dietitian to your home care coordinator, physician, driver, personal care aides. Every one of those individuals has their own unique perspective and brings that perspective and expertise to the table. So kind of gave a high-level overview of what PACE is, but how is it reimbursed and how is it different? So I mentioned that we're not a fee-for-service world. I won't get into the nitty-gritty of Medicare and Medicaid payment methodology, but at a high level, PACE is a capitated and fully risk-bearing model of care that provides those wraparound health and wellness services to individuals that are over 55 and that have been assessed to have a nursing home level of care need. So put another way, it means that a PACE program receives one fixed payment. Again, this is a little bit of an oversimplification, but they receive one fixed payment from Medicare and Medicaid for each enrollee in the program. So these funds are pooled, and they're not necessarily assigned to one individual. They're pooled into a larger insurance pool, if you will, and the IDT can use those funds as necessary for each individual. Essentially, we are a nonprofit insurance program that is also the provider, in that we're getting the Medicare funds, the Medicaid funds, and the Part D funds all pooled together. And maybe 1 month, those pooled funds are $5,000 a month for that member. Well, their cost might be $2,000 that month, or their cost might be $40,000 that month. The reimbursement does not change. So we're fully at risk for all of their health and wellness needs. So we're incentivized to provide more preventative and proactive approaches to reduce high cost for this very medically complex, high needs participant base. So before I dive into the details of how this intersects with the Rural Health Transformation Program, I do want to provide a little bit of context about the larger healthcare funding ecosystem, given that the Rural Health Transformation Funds are one small component of HR 1 or the One Big Beautiful Bill Act that I'm sure you've heard a little bit about over the last couple of years, given that this legislation is projected to result in a little over $1 trillion in Medicaid cuts over the next 10 years. And this is all while around 40% of rural hospitals operate at a loss. And there are over 700 hospitals nationwide that are at risk and around 300 that are in immediate danger of closure. And these Medicaid reductions have a significant impact on rural communities. And that includes, but isn't limited to, the shrinking of care networks, due to healthcare infrastructure closures, workforce shortages, increased cost, and decreased outcomes. And given that older adults are disproportionately concentrated in rural areas, I think it's important to recognize that these issues have an outsized impact on rural older adults. But rather than focusing on some of those challenges, today I really want to focus on the solutions. What are we doing about it? How can we make lemonade out of the lemons that we have, so to speak? So that's where the Rural Health Transformation Program comes in. So the Rural Health Transformation Program, as part of the HR 1, focuses on a couple things: aging in place, dual eligible integration, rural hospital partnerships, and alternative rural health access models. So all of which really perfectly align with the PACE model of care. So there's a pretty decent history, actually, of federal funding for PACE expansion over the last few decades. The earliest window of this was in 2006, where they released about $7.5 million in relation to a rural PACE program grant. It was funding for 15 sites across 13 states. Then fast forward to 2025, HRSA proposed a very small rural PACE expansion grant. Unfortunately, it was later withdrawn and wasn't able to come to fruition. So really, the Rural Health Transformation Program is by far the most significant public funding source for PACE expansion in the history of the program. So just to give you an idea of where PACE is specifically called out within the Rural Health Transformation Funds, here's a little graphic. If there's any geography aficionados, we've got Kansas, Oklahoma, Florida, Pennsylvania, and Rhode Island called out here. So Oklahoma, I'm going to go into specifics of what the Rural Health Transformation Grant projects specific to PACE are. Because if we go back, the details, in total, the bucket is around $50 billion over 5 years. And each state was responsible for putting together their proposal to CMS for how they would operationalize these funds. So they submitted their proposals to CMS, and CMS then came back with approval. Now, several of these states within that proposal response specifically called out funds for PACE expansion and investment. So I'll go into kind of the details of what those specifics were. So in Oklahoma, they committed approximately $35.2 million over 5 years, including about $15.2 million in the first year, making it the clearest and most aggressive rural PACE investment identified in all the current rural health transformation landscape. The initiative specifically contemplates the development of 3 to 6 rural PACE centers across underserved areas. In Rhode Island, they're incorporating PACE into a broader initiative that calls out for about $7.27 million for a Block Island Rural Health Initiative, and using the island community as a test case for innovative rural and geographically isolated care delivery models. They're going to work with an existing PACE program called PACE Rhode Island and Block Island Health Services in the town of New Shoreham to develop a new PACE program there. In Pennsylvania, they reference PACE within a broader statewide effort focused on aging in place, dual eligible integration, and modernization of aging services, coordination systems, but haven't really specifically identified those plans or those funding amounts at this time. Same thing in Louisiana. Their strategy references the development of alternative care sites within existing rural hospital and community infrastructure. So PACE centers are kind of the main hub of PACE care delivery, but there are additionally what they call ACSs or alternative care sites. Think of them as PACE Light, and existing PACE programs use them to expand their service areas. So that's what Louisiana is doing. But then here at home in Kansas has allocated approximately $7.5 million in year one for PACE expansion, after identifying that there are around 4,300 rural Kansans, and this is 34% of PACE eligible residents currently lack access to a PACE program within a reasonable geographic distance. So their PACE expansion is, rather than building an entire new ecosystem, they're looking at leveraging two existing PACE providers, along with rural health partnerships and health telehealth capabilities in order to expand existing programs into counties that are not currently served or have access to PACE programs. So what are the fundings, these funding systems paying for? In some, the Rural Health Transformation Program is really providing a generational investment in PACE expansion. In the context of the larger legislative environment and funding challenges in healthcare, it's not a cure-all, but it will result in the proliferation of PACE organizations, which really have been proven to deliver excellent quality of care and outcomes for participants and significant cost savings to states since their inception in those respective service areas. It's really, this round of funding is really distinct in that it's not just here's funds to open a PACE center. It's really designed to redesign how PACE organizations can reach into more rural communities and invest in capacity building for models of care that have shown efficacy over the years, and really focus on those initiatives that the Rural Health Transformation Program were focusing on, such as dual integration, long-term sustainability, and investment in value-based care, as Kim mentioned earlier. So that is what I have to share with you today around PACE expansion in the context of Rural Health Transformation Funds. Thank you.
All right. Thank you very much, Heath. That was great. I learned a lot. And I loved, definitely, I'm sure people have some questions about the Rural Health Transformation Grant, but also just the model of care that PACE is and has, and how ahead of the curve it is in terms of value-based care. It's also really impressive. So thank you for that. And our next speaker will be a policy perspective on the safety blueprint, why resident rights are the foundation of modern senior care. And we'll be hearing from Hector Rodriguez, who is the Kansas Long-Term Care Ombudsman. All right. Oh, perfect.
One that says to this one, right? Yes.
Yes.
What is it? Where's my icon?
Here's
Oh, it's
good
that one. There you go.
You good? All right. Yes. All right. A little bit more pressure on me. I'm the only one in person, so I think.
Last minute emergency.
Right. Yeah. No, I get it. Yeah. No, I get it. But it's cool though. I prefer to do it in person. My dog's really loud. For some reason, she just snores all day, and like I couldn't have done it at home anyway. So it's fine. It's cool. Thank you to the Institute for inviting me today. I am the I was gonna say Texas Long-Term Care Ombudsman. No, that was before. I'm the Kansas Long-Term Care Ombudsman for Region 3. My region covers Wyandotte and Johnson counties alone. Just in those two counties, I oversee 120 facilities, and it's just me. And I still made it. And so I did. Um, and so one of our biggest things is to go out to facilities as much as we can to visit with residents one-on-one, let them know that, hey, this is not the end all be all to your life, to your healthcare. We want to make sure that residents are aware that they do have a certain afforded rights that are particular to long-term care. And it was an interesting topic to be part of this forum because I think that there's a lot of confusion with resident rights and how they're used, how they were applied, how they're interpreted. And so I guess without further ado, we'll start this thing. I'll just do that little arrow symbol. All right. So about us. So like I said, we are advocates. That's what we are first and foremost. We are a resident directed program, which means that the resident, are my boss. And I do tell them that. I tell them, you are my boss. You tell me what to do, what not to do, what to say, what not to say. Because in the end, we want to make sure that the resident, every decision goes back to the resident, or at least that they feel empowered to make that decision. We understand that sometimes, with the resident, they might have different physical, cognitive abilities that they can't necessarily make that decision on their own. So we often turn to their legal representative, which usually is a power of attorney. In some cases, there are guardianships and conservatorships, and so, or just the spouse. But so yeah, we turn to them as well. We're also educators. We go to facilities. I tell my facilities, I'm here to help you help the resident. They use us a lot as a point of reference with regard to compliance issues, regulatory issues. A lot of times because, it's good to call me first because if they don't, usually state shows up. And so I'm kind of like the last resort before state. And usually when people do reach out to me, a facility does, is usually on a reactive as opposed to a proactive approach to the situation. And so, but also we do represent the residents' interests before government agencies. Our state ombudsman, Haley Ordoin, has been extremely busy this entire year so far, going into committee meetings, meeting up with other elected officials in Kansas, trying to promote resident rights, trying to let them know of other issues that are going on in long-term care. Most of the problems that do happen in long-term care are systemic. And so with that, you have to go towards policy and try to change policy. And as we all know, policy takes a long time. So about me, I am from Texas. That's my outdated LinkedIn picture. I've been working in geriatric care for quite a bit. I started off with my mom, who had been diagnosed with dementia. And slowly but surely, my career from wanting to be an attorney came to doing this. And I did experience, with my mom, having to navigate long-term care, not knowing what to do when you're 21, 22. You don't know anything. A lot of people don't know much about long-term care because we don't know until it happens to us. And so, but I've also been a director of caregiver information and resources back in Austin, Texas. I've also been an ombudsman in Texas. And so I have a unique perspective because I was an ombudsman up to COVID and into 1 year of COVID. And then I took a break from that and then came back. And so now I see long-term care post-COVID. A lot has changed, a lot is not. And so yeah, and we'll talk about that here in a second. And so this is our mission statement. I'll read it verbatim. The mission of the Office of the Long-Term Care Ombudsman is to enhance the quality of life and quality of services in Kansas adult care homes through advocacy, education, and empowerment. Ombudsmen promote person-directed living, which respects individual values and preserves the individual rights and preferences. Do many of y'all know what resident rights are? I'm pretty sure we've heard of patient rights, right? And so they're very similar, but this is very particular to long-term care facilities. I would say maybe like half of, 5 out of 10 residents don't know they have residence rights. Facilities are required to make sure that they let them know about the resident rights when they are first admitted to the facility. But usually that paper goes at the end where, that it's not upfront. And so people don't know that I exist, that our program exists. And some of the resident rights are, respect to dignity and quality of life, freedom from abuse, neglect, and restraints, exercise of rights and self-determination, information and communication, the right to participate in your own care, the right to have privacy and confidentiality, the right to air grievances and file complaints, and also the right to proper admissions, proper transfers, and discharge rights. Also, the right to have a say in your own finances and belongings. And finally, you have the right to have visits and have group activities so you can have a social life, which is also a huge component to long-term care. And so, sorry about that. So a lot of people see that, the resident rights are more of a checklist, compliance, regulatory checklist, and facilities don't really see it as literally a blueprint to help improve care with residents. And so with this, with facilities looking at resident rights as a checklist, it becomes very institutionalized. And so you always got to check the box. And again, doing that doesn't really put the resident forward and making, truly resident-centered care. And so slowly but surely, the industry is trying to get away from that. A lot of facilities, do try hard. A lot of facilities don't try hard. And so, but we want to make sure that the resident feels at home, again, because it is long-term care. And so chances are, once you're in long-term care, you're going to be there for a while. And so, yeah, we want to make sure that it is truly resident-centered care. And so what is our vision? And so we want to make sure, like I said, from an institutionalized setting to a more home setting. The SOLD system, like I said, is very task-driven environment. It's focused on healthcare compliance, very rigid schedules, and sterile efficiency. And so what we want to, like I said, what we want to do is get away from that, completely opposite of that. And again, it's not really revolutionary. It's nothing out of the box. It's been there forever, the resident rights. And again, it's just not been used properly. And so with that, I'll start with the resident rights. The first one is the right to self-determination. This is a big one. This is the one that we always emphasize that, hey, you are in control of this. You are the one that gets to say whatever you want in your care plan meeting. We want to make sure that the resident understands that they have total autonomy of everything, of themselves. They have the right to choose activities, schedules, healthcare providers, and waking up and going to sleep at their preferred times. I don't think that, I think we've all had it at least one time that your parents, when you were kids, woke you up right before school, you slept in 5-10 minutes later, they flip the switch to the lights, and you're like, no, go away. No, it's not like that sometimes in long-term care. Just because they're in long-term care doesn't mean that they have to adapt to the staffing schedules. We want to make sure that the resident feels comfortable in waking up as opposed to getting up at certain times just to appease the staff changes. There's also, dining times. That's one thing as well. We want to make sure that there are, 24-hour flexible dine-in with open kitchen concepts. There are a few facilities out there that are trying to adapt this. One that comes to mind is Nottingham over in Overland Park. They have actually 2 kitchen open concepts, and it's pretty nice. And so, but again, we want to make sure that the resident has, the say from morning, from dusk till dawn and everything in between. And as well, let them, be in charge of the calendars, driven by resident councils, other kinds of clubs, and not necessarily, the activities director scheduling. Also, the resident has the right to personal property in a home-like environment. So the resident has the right to keep and use personal belongings, wear one's own clothes, and live in a home-like environment. So what's the reality? Identical, sterile, double occupancy rooms pretty much in every facility. If you're in Medicaid, 98% of the time, you're going to have a roommate. That's it. There's no privacy in that. And so what we want to advocate for is for, a more private setting. Again, it's only a sheet, what do you call it, a curtain that separates you from your roommate. There's zero privacy. To receive care, to have to be able to visit with your friends and family or visit with other residents in the facility. We want to make sure that we want to encourage the resident to bring their own furniture when that's possible. Of course, it's kind of a little bit difficult when there's two people in one room, but again, we want to make sure that the resident knows that they can bring in their own furniture. The right to privacy and confidentiality. And so the resident has the right to private personal care and unrestricted private communications and protected medical and financial records. So one of the privacy issue, a big privacy issue is, I see this all the time, is CNA will, it's the morning or the changing shifts. He or she walks in, knocks on the door, doesn't say anything. It just walks in. You wait, you knock, and you wait to be let in because that's somebody's home. That is not your home. What if we did that to somebody else, a stranger? It wouldn't go too well. So why can't they do that in the facility and respect that, respect the resident's home? It's also, there's not a lot of private spaces in long-term care facilities because usually there's a lot of communal settings in long-term care. If you want to visit with a friend or a family member, you usually have to do it in your room. And again, you probably have a roommate. If you are in a skilled nursing facility, it's a little bit different assisted living, but also, there isn't really many areas that you can have privacy. And also all medical charting and shift huddles handled discreetly via mobile devices out of sight of common areas. There's actually no regulatory rule, nothing like that prevents the CNA to have a cell phone out when they're passing out medications. Surprising, but there isn't. But I do bring that up. When I do see that, I will approach CNA, the med tech, and then eventually the director of nursing and say, hey, I don't, in hall, whatever, there was a CNA, there was a med tech out with their phone. Of course, you're distracted, especially if you're a med tech, you're distracted. That is just something bad's going to happen with that. And so we try to avoid that. And again, there is no regulation against that. So the resident also has a right to visit and community access. And so the reality of this in long-term care setting is that a lot of facilities have visiting hours. They make you sign in and sign out. The resident doesn't have to sign in or sign out, period. They don't. What they'll tell you is we want to make sure that we know who's in the building and who is not in the building if an accident, an emergency were to happen and we have to evacuate. No, you don't have to sign in. Visitors don't have to sign in either. The only time I do recommend that they do sign out is that if they're going to be spending a day or two outside the facility is to sign out. So in case that, they are there on the Medicaid bed, that allows the facility to at least have a data record of when you left the facility. So again, one of the things that we advocate is that there aren't any necessarily visiting hours. This is a problem that actually does come up quite a bit. Residents can visit with anybody at any time, anywhere in the facility. But of course, if they become disruptive, they're being disruptive to the community as well. And so, but yeah, make sure also facilities, this happens a lot. A lot of facilities promote that they have transportation available and their buses, hasn't been working in months. And so that creates a lot of other problems as well, because one, a resident who, I don't know, used to go to church on Sundays, to their church on Sundays. Now they can't because their bus is not working, or they're missing appointments, because their bus is not working. And when they do get transportation, they miss the transportation, whatever. Um, so that's a very big, important thing, is to try whenever they can to provide transportation. Also, they have the right to participate in care. Um, they have the right to be fully engaged in their care. This is 100% non-negotiable. A lot of times in care plan meetings, the team is there to talk about the resident. Many times, the resident is there, and not once I've been in those care plan meetings, they address the resident and they just talk and make decisions for that resident. And this happens a lot. Usually when I am part of those care plan meetings, I do try to bring it back to the resident and say, hey, do you have any questions? Do you understand this? And so that's another thing too. When I think we've all been in a situation where we're talking to a professional, whether it's a mechanic, a doctor, whatever, they start speaking in their own jargon, their own lingo, and we're like, what the heck are you saying? Like, I don't understand anything. So they get caught up in that. We want to promote, that the providers are speaking to folks in layman terms, things that they're able to understand. We want to make sure that, whenever there is a care plan meeting, that it's not, most of the times the care plan meetings or in the conference room. I was a rambunctious child as a kid, and so I spent a lot of time in the principal's office. And so every time I go to a care plan meeting into the conference office, that's what I feel like I'm getting into. Like I'm going back to the principal's office. And so we want to promote, and I actually asked the resident if they want to do this, is to have the care plan meeting in their room when possible, because again, it might not be possible because they might have a roommate. And of course, we can't discuss, other health issues around other people because of HIPAA. And so, yeah, we want to make sure that the resident is fully informed whenever it comes to making decisions about their health care. And so, yeah, that is a big one for us. Freedom from abuse, neglect, and restraints. This is a big one. Unfortunately, all the horror stories you hear about nursing homes is true. I've helped in many cases. But a lot of things right now, what we're trying to get away from is using sedative medications or physical barriers to manage complex behaviors for staff convenience. Usually, of course, you can't sedate a resident. And so what will happen is that they will send out the resident to a Jerry psych hospital, get their medications evaluated, and then come back. And more than often, they don't let them come back actually because of behaviors. And so, but when you ask them, like, what did you do to, to help the situation? Did you distract the resident? Did you tell them, hey, let's go for a walk? No, nothing. They just go straight to the problem and they're out the door to a Jerry psych unit. And so, and again, a lot of these facilities are really nice. But again, they don't use these settings, like with their gardens or their long hallways as tools, because again, these are things that are there to help the resident as opposed to just sending them out for behaviors. And of course, the right to voice grievances. And so the resident has the right to say anything. They have the right to make any kind of complaint, whether it's to me, whether it is to KDADs, whether it is to the media, whether it is to whoever it is. Unfortunately, there is retaliation when folks do file complaints. The complaints are seen as burdens and not really. The way I see it is more like a quality assurance report anytime somebody does submit a complaint. It's like, hey, here's a chance for us to become even better at to do something and to do it better and to do it right. But no, it doesn't often help, doesn't often occur like that. And so, and this is when they call me a lot. And so yeah. but yeah, it is important for the resident to know that they do have that right to complain. Unfortunately, one of the things that the residents will tell me, they'll list a whole, list of grievances, and then they'll say, "But I don't want to get in trouble. I don't want to get somebody in trouble. It'll fix itself." It doesn't fix itself. It gets worse. Um, and so again, but we have to respect that. If they don't want to proceed with that complaint, then we'll leave it at that. And so the best that we can do is at least provide some guidance on how to navigate that issue. But again, we leave it up to the resident. And so in closing, every resident, regardless of cognitive or physical acuity, deserves the full protection of their rights as an active citizen. Scaling this model is not a luxury. It is a moral imperative for the 21st century aging. That's our contact information. And there you go.
Thank you so much.
All right.
Thank you so much. Visitors, drop your questions in the chat. We have about 8 minutes.
Yes.
For some Q&A.
We sure do.
I see one. There's a question for Kim. Stacy, I don't know, can you get to?
So first, thanks to all of the speakers. Those were fabulous. I think we had a really good, diverse mix of perspectives on senior care and new directions. Yeah, I'll definitely get to the ones in the chat, but even in before then, we touched on so many topics. It's like hard to even say where to start. I curiously, while I get into very specific questions, I think I'd love to hear from each of the speakers individually and just what to them is the most pressing, urgent thing that we should be mobilizing on, centering on, trying to focus on, as a community or as a region, because we know that it's so big, right? The population the size is doubling, and by 2030, our current healthcare financing system and delivery system is clearly not equipped, to handle it. So patchwork and piecemeal. The funders, the payers, the workforce alone, I think, is also a very unique and interesting perspective, given not just the lack of primary care providers, but also informal paid care, unpaid family caregivers. So thinking through workforce, financing, care delivery, and the fact that the population's aging and we already have provider burnout and people not going into primary care, et cetera. So it's kind of what are the big ones? So, or maybe I'm just listing a few of them that we all know.
And Stacy, if I could jump in there, given the time,
if
each presenter could give us a sentence of the one thing.
Yeah, that's what I'm saying. Just if you could speak to in your own experience, where should we mobilize? Yes, that would be awesome. In a sentence, according to Pat, she's very much timekeeping us. We appreciate Pat. So, but while we're waiting on those responses and you're collecting your sage wisdom for the group, I would love to see. It's a little hard for me to read.
You want me to read it?
Yeah, I can make it bigger.
Kim, in the chat.
Yeah, for Kim, you really highlighted the degree to which CMS is driving digital health across the board. Are there any actions in the region? 7, directed toward getting organizations to pledge to the CMS Health Tech Ecosystem Initiative or anything else related. Oh, and she responded, but I don't know if there's anything else you wanted to say out loud or for the group.
Maybe the inside audience, they can see.
Yeah, just that it's not a regional push necessarily, and there are multiple national pledges for many different categories. There's the explanation of the categories here, and she provided the URL, and there are also early adopters and pledgees and how you can sign up. So there's that one. Okay, well, then that being said, who wants to start? We just go, whoever would like to start, you may unmute or come up to the mic and, enlighten us with the answer to fixing some of our challenges, or what's the biggest challenge from your lens, or what can we do as a community to reach it?
That if they tipped it, might start getting where you want to see us go, right?
Yeah, interpret it how you must, but I want to hear your. He's unmuted. I see him as a willing volunteer.
Sure. So coming from kind of the operations perspective, I think that the biggest threat is a lack of quality workforce that is willing and able to meet the challenge. As we have to scale our infrastructure, we hear every day conversation about white collar jobs or creative jobs being taken by AI. I don't know that we're anywhere close to that in the direct caregiver world. Maybe some of the back office administrative functions could be automated or create efficiencies there, but we're still going to need doctors and nurses and physical therapists and home care aides to provide that direct care service. And given the volume of older adults that are aging into those needs, I just do not know that we currently have the necessary infrastructure. So I think we have to be building pipelines to healthcare professionals early on. I mean, we're talking early high school, create programs that really encourage people to get into this field because there's job security, because there is need, and it's an amazing field to work in. The helping professions are, I think, needed, and in order to have the workforce, we also have to have the funding ecosystem in order to make it a attractive job, financially as well.
Well said. I totally agree, and also great perspective. Yeah, in the room, you can, I think, speak up loudly, and they should be able to hear you.
I'm a recently retired primary care physician, and to me, the entire industry is broken, and it was not constructed ever with thought. So, CMS. I worked in value-based pay. I was one of the first in primary care first. And that was a dismal program, not designed for primary care to succeed. Primary care, you do not pay. I owned my practice. You do not pay primary care adequately. You don't support primary care. People are not going to go into primary care because it's seen as the least viable, most controlled by the powers that be, the insurance companies, the hospitals, and it's all about numbers, and it's not about relationships and establishing the foundation, which primary care needs to be the backbone of healthcare. And we can save 20% in healthcare costs if you have a robust primary care to take care of patients, because then they don't have to go to the specialist to get their headaches treated. They don't have to go to the orthopod just to get a joint looked at. This is a major problem that CMS needs to address. I have not seen it, and I was in healthcare for 46 years. I've seen it gone downhill, downhill, downhill. Again, I was aggressively involved in value-based pay, and I worked myself silly, and I had to get out of it because I couldn't do it anymore. I was burned out. So you need to look at how can primary care become the backbone that it should be, and that people want to go into healthcare, be primary care physicians, and to be involved in primary care.
There you have it.
Thank you. Thank you for that. I can hear, and thank you. Yes, absolutely noted.
I spoke with one of the directors for creating primary care first. The goal we had to meet as a small office, I had 3 nurse practitioners and myself, for primary care first, was hospital costs for the patients. We failed uniformly on hospital costs because we'd have 1 patient get admitted or 2 patients get admitted. If you had done all costs in patient care, we knocked that out of the ballpark every month. Mm-hmm. And he said that there were two groups. One wanted to do all costs, the other wanted to do hospital costs. It made no sense to me to just base it on hospital utilization.
So maybe
Yeah.
this region could advocate for dismantling CMS. I mean, we have a president who likes to dismantle things, and maybe we could have it dismantled and rebuild something that actually works.
Well, we'll save some of this discussion for the after party is what I'm going to say, because we are at time. I want to be really respectful of everyone's time. I will say, very interesting, and I have, also a lot of thoughts. There's a lot of different CMS models. I mean, even other ones pushed at kind of changing the workforce, like the graduate nurse education demonstration. I worked on that one. Like, how do we start to fill the workforce needs and get more people to care for these patients? And I think feedback, especially from providers who have been through these models and tried to make them work, are really, really good lessons for what doesn't work and how CMS can, take that feedback and, iteratively improve some of the models. Yeah.
I might have missed it, but is the levy permanent or temporary?
That question would be for Laura. The question in the audience was if the levy was permanent or temporary.
Oh, great question. There's no sunset, so it's permanent into perpetuity. And my just other short answer about that is public policy is so important. There's a lot going on at the federal level in terms of cuts and lack of Medicaid expansion in Kansas, shockingly bad budget cuts in Missouri for aging services. And this passage by voters in the county allow residents should take a little bit of control with where their tax money goes. So I've got a policy background, so I'm always going to do a shout out to that. But yes, it's there is no sunset. It is forever unless something changes with the unless the voters repeal it.
That's great. Okay, well, let's all